Good morning, everybody. We're going to be talking a little bit about the treatment of ischemic stroke and the neurosurgical role that we have in the treatment of these patients. A few years ago, I have a lot of trouble trying to convince the people who was in charge of our website to include a stroke program in the website because it was not recognized as part of what we do as neurosurgeons. In fact, if you look at the audience today, the people that is forced to stay have stayed, but in general, still, a stroke is not considered something that is a neurosurgical issue, but more something that is a neurology issue. I don't have any peculiar disclosures to do. But that problem of the interventions that we can do for a stroke and how we can participate in a stroke is actually quite a myth. Probably one of the fields that have some of the most valuable information and some of the best clinical studies regarding interventions for the treatment of a stroke, or intervention for any treatment, is the field of a stroke. We're going to be talking today about approximately 30 clinical trials. Of those, 25 were prospective, and several of them are randomized clinical trials that show the importance of some of the interventions that we can do for the treatment of a stroke. And the fact that a stroke involves not only the lack of blood flow going to the brain, but also the bleedings that occur in the brain was recognized a long time ago. In the 18th century, Jean-Baptiste Morgagni was the first one who actually came with an idea of the pathophysiology of what was called at that time apoplexy. And apoplexy had been something recognized from Galen times in the 1st century, but there was not an understanding of what was the pathological process that was involved. Morgagni, by doing the dissections and correlating that with the clinical findings of the patients, recognized that there was two types of apoplexy. Patients that have excessive blood, usually bleedings in the brain, and he called that sanguineous apoplexy, and patients that have excessive water, he said, and he called that serous apoplexy. And this actually is quite similar to the definitions that we have today of a stroke. We know today that it's not an accumulation of blood or fluid what causes a stroke, but a problem of the vessels that are leading or within the brain what causes a stroke. And those pathological processes that affect the vessels of the brain can be narrowing, occlusion, and rupture. So a stroke actually involves both hemorrhagic strokes and ischemic strokes. And we're going to be talking today about ischemic stroke and the interventions that we can do as neurosurgeons for the treatment of ischemic stroke. We're going to divide the conference, the presentation, in these 4 subjects. First, we're going to be talking about the acute endovascular management of a stroke. Then we're going to be talking about the acute surgical interventions for a stroke. And we're going to refer to the surgical and endovascular interventions for the treatment of carotid stenosis. And finally, we're going to be talking about the surgical and endovascular interventions for intracranial stenosis or occlusion. So the first point links with what Dr. Ali showed you in the last 100 conference regarding the acute endovascular stroke management. And a concept that she mentioned that you need to understand clearly is the importance of time in the treatment of a stroke. Before a few years ago, basically patients with a stroke were treated conservatively, putting them in a room and just letting the disease take course. But the understanding that there is salvable tissue in the brain became a fundamental step to be able to treat patients with a stroke. Within minutes to hours from the moment that the circulation is arrested in a portion of the brain, a series of events start occurring that are going to finally produce the final damage of a stroke. And this slide shows a little bit of those events. The first one is, of course, the bioenergetic failure that occurs immediately after there is not enough blood going into the brain. That starts in the moment the occlusion occurs and lasts for several hours and produces some of the damage. But in terms of the magnitude of the damage, some other processes that are elicited also within minutes are very important. Once the cells start suffering because of the bioenergetic failure, they deliver a series of excitatory amino acids, and glutamate is one of those very important. That process is called exotoxicity, and the exotoxicity takes care within hours, but extends to within minutes, but extends within few hours from the moment of the stroke. That is also followed by the oxidative stress that is produced either by the ischemia or by the reperfusion that sometimes occurs spontaneously, and is associated also with the microvascular injury by the non-stop phenomenon that I explained to you when we talk about vasospasm. Once the blood flow is arrested in a portion of the brain, in addition to the bioenergetic failure, the blood that is staying in the capillary bed distal to that occlusion thromboses, and that produces microvascular injury that is due to the thrombus formation in those small vessels, but also to the aggregation of platelets and inflammatory cells that is going to generate this part of the curve, the post-ischemic inflammation, that is going to play a very important role in a stroke. And finally, the last process that intervenes in the pathophysiology of the stroke, that is the disruption of the blood-brain barrier, that starts within hours. But basically what this indicates is that there is a window of treatment that could be used to try to reverse the different processes that affect patients with ischemia, and that window is within few hours. And the basic paradigm that guides the treatments that we do for acute strokes is the paradigm of the perfusion-diffusion mismatch, or the presence of a core and perfusion area of mismatch. Basically, once you have an arrest in the circulation in a portion of the brain, very rapidly, the central portion of those areas of the brain that are not being perfused are going to suffer ischemia, and they're going to be damaged irreversibly, and that portion of tissue is what is known as the core. But around the core, there is a portion of a structurally intact but functionally impaired brain that can be saved. And the disproportion between the core and that area that is around, that is the perfusion mismatch, is the battlefield for what we can do for patients with acute stroke. And as Dr. Ali explained before, the idea is that the intervention should be done in such a manner that we save the majority of that tissue that is functionally impaired but structurally intact. And for that reason, we have these schemes of treatment for acute stroke that allow very rapid transportation and recognition of the stroke in the patient from the field to the primary stroke centers and to comprehensive stroke centers like here UCLA, where we can do then interventions that expand the window of treatment from the 3 hours that are allowed for the medical treatment with the intravenous TPA to longer periods of times where we can do other series of endovascular procedures that allow to rescue some of that penumbra tissue that is at risk. The problematic part of this is that the results are still a process that continues growing and improving, and we have a series of devices and techniques that can be used. And what we're going to be doing almost from now until the end of this conversation today is to review the evidence that we have to support those interventional treatments. And the first one is the use of intraarterial thrombolysis. And Dr. Ali also mentioned briefly the PROACT study that was the first one that tried to do an intervention for a stroke beyond the intravenous application of thrombolytics. And basically what we do in these patients is that we navigate catheters into the arteries that are occluded, and we can deliver doses of TPA, or like the PROACT study, PROLYSE, to induce disruption of the clot. Now, currently, there are no approved intraarterial injections of any material by the FDA for the treatment of a stroke. And there were some issues. The fact that this study was done almost at the same time in the intravenous use of the TPA, and there was really never a comparison between the two of them, is the main reason why the FDA didn't approve this treatment. However, it's a very commonly done form of treatment because it happens to be quite effective in a good proportion of cases. If you look at the results of the PROACT studies, the first one is the recanalization rates. For patients that were treated, the recanalization rates were 66%. That is significantly different than those that were not treated. And this is advantageous because if you reperfuse the brain, then you have the chance to stop some of those processes that we discussed. In terms of the outcome, the measurement that was used was the 90 days modified Rankin scale score of less than 2. And that was also significant. For patients with the treatment, it was 40% versus 25% for the patients without the treatment. And this, of course, shows that there is some benefit in opening those arteries. The mortality between the two groups was not different. However, there was a problem with the use of the intraarterial TPA, and it was an increase in the rate of bleedings that was not significant, but very close to be with 10% patients suffering from intracerebral hemorrhage when they use the intraarterial TPA. So as I mentioned before, we don't have exact regulations of how to use this. However, we still do it, and it's especially effective for patients with the distal occlusions where you cannot reach with other means that we will discuss those clots to be reopened. But still, there are some problems. Even though it expanded the window of treatment, the window is still limited to only 6 hours. It was not very effective if you have very large clots, especially in the carotid or in the MCA. Those clots were not easily disrupted by the use of intraarterial lytics. And there was a significant amount of intracerebral hemorrhages associated with this. So several studies were published in the 90s and at the beginning of the 2000s trying to see what else we could do to try to improve those results of the use of intraarterial thrombolytics. And all of them recurred to the use of mechanical means to open the arteries. Some of them use angioplasties. Some of them use angioplasties and clot maceration. Some use the small retrievers, like this snare, to try to capture the clots and bring them down. And in general, what we learned from that experience of using mechanical means to open the arteries was that it appeared to be successful. This was not a randomized study, it was just a retrospective review, but in the study that Qureshi published in 2002, the recanalization was significantly higher than in the PROACT group, being 84% versus 66%. When they used the mechanical devices, it appeared that the risk of bleeding was less because you were not given a pharmaceutic agent that has the tendency to produce bleeding, and in that report was 0. And the clinical outcome was similar to what was being seen in the patients with the PROACT that was already a step ahead of the medical treatment. Based on that idea, in the year 2000, we worked here with Pierre Gauvin to develop a mechanical device that would capture those clots and reopen the arteries. And the idea that we originally had was to try to use it without thrombolytics to reduce the risk of bleeding and improve in that aspect of the treatment of the patients with a stroke. We also had the hope that by using a mechanical device, because we were not using thrombolytics, we could actually open the arteries beyond the window of 6 hours and expand the window of treatment at 8 hours. We were thinking that if we use thrombolytics, the risk of having bleedings would be higher anytime above the 6 hours. And with that in mind, that study, the MERCY one, was performed, and this study was in a small clinical trial. It was not controlled and it was not randomized, where 30 patients were included. These patients have an NIH stroke scale of more than 10, and the treatment window was expanded to 8 hours. And the results were very good in general for a small study, good enough that the FDA approved this device as a mechanical form of treatment for patients with acute ischemic stroke. Those results were only one procedure-related technical complication that didn't have any clinical consequences, and there was 12 patients that would have asymptomatic and 1 symptomatic intracranial hemorrhages. The recanalizations rates, however, were not that good. They were compared a little bit lower than with the PROACT when we used the MERCY only. And then in patients that had received IV TPA, when we did the MERCY device, we have a little bit better result, just comparable with the PROACT. But it had the advantage that we could expand the window to 8 hours of treatment that you could not do by the use of intraarterial thrombolysis alone. Based on those results and additional changes in the design of the device, including these little strings to try to capture more clots, the second study was done, and this was a multi-center clinical trial. That was the multi-MERCY study. And there are some important things that you need to remember, so in the next slide makes sense some of the results. Basically, the idea was to evaluate the efficacy and safety of this modified device. It was a larger study where 164 patients were included, and the clinical condition of this patient was slightly worse. It was patients with a stroke scale between 15 and 23. And this is the description of the places that were occluded, being the majority of them localized in the middle cerebral artery. And for the results, probably they're better visualized in this comparison. Remember, these studies were not made to compare one to each other, and this graphic is technically or statistically incorrect because they were not made to be compared. However, it gives you an idea of how the MERCY device compared with the PROACT clinical trial. In terms of recanalization, this is the control for PROACT. Remember, MERCI didn't have a control. And in PROACT, we say that 66% of the vessels open. The MERCI was comparable with the 64% of recanalization rate. The outcome at 90 days was also similar to the one of PROACT. In PROACT was 40, in the MERCI trial was 36%, which was better than in the control group. The mortality, however, was higher for the MERCI device, was 34%, but remember also these patients were patients with high grades of stroke, and they were being treated up to 8 hours. So there was an increase in the mortality. And something that is still a little bit curious was that the hemorrhage rate actually was not low. We were expecting that by using a mechanical device and not using intraarterial thrombolysis that would improve, but that didn't. Fortunately, it wasn't higher than what has been seen with the PROACT. And in general, this study confirmed that the mechanical device could be used up to 8 hours to treat patients with intracranial occlusion of a vessel acutely produced by clot. Of the good things that we learned with the MERCI trial was that outcomes that were good and mortality were clearly affected by our ability to open the vessels. When we were able to recanalize the artery, the good outcomes were present in 50% of patients versus 10% when we were not able to open the arteries. And the mortality was also significantly affected. It was half in patients that we could recanalize. Then that set a little bit the direction of what to do. It was clear that we were not doing as ideally well as we would like. However, this was an improvement. We had been able to extend the window of treatment for only 3 hours to at least 8, without a significant increase in the mortality or the rate of complications. And clearly the point was how to open these arteries, and that was the focus of the next significant clinical trial, that was the Penumbra stroke trial. So this device is actually a catheter with a large board that has a separator that is this little wire with a fusiform plastic tip that allows to clean the tip of the catheter, and the catheter is connected to a low continuous suction. So it's like a vacuum for the clots that is advanced into the clot, and basically the clot is aspirated. The purpose of this study was, again, to assess the safety and effectiveness of the device. There was no control group and no randomizations. Included 125 patients, and the stroke scale was actually lower than for the MERCI. So these were patients in general in better condition. The successful recanalization was quite good using the Penumbra device. It was 82% of the target vessels. However, the rate of complications was higher than with the MERCI device, and the clinical outcome was not as good. Let me put the next slide because that illustrates better the things, comparing them with the other studies. So, excellent recanalization rate, but the clinical outcome was not that good. As you see, it's only 25%, that is barely comparable with the control group of the PROACT. And a mortality that was high, and a rate of bleeding that was even higher than for patients with the MERCI device. So this is where it becomes a little bit confusing, because now we have a device that is not actually even irritating the arteries of the brain. You are not snaring anything. You are not necessarily damaging the endothelium. However, it seems that the results are not really that good. And that event that we have noticed in the patients of the MERCI trial, that when we open the arteries, they have the tendency to do better, didn't happen in the MERCI, in the Penumbra trial. There was more arteries that were open, but the patients were not doing that much better. Part of the explanation of that has to do with the design of the clinical trial. And this shows how complicated it is to understand and to make these studies in a stroke. For the Penumbra clinical trial, the investigators decided that they were going to look at the target vessel and how much of that vessel was open, but they didn't look at the distal area that was perfused by that artery. In the MERCI trial, the clinical criteria of opening of the artery was in consideration also of the distal vascular bed. So it doesn't matter too much if you open the artery if the distal vessels get little clots and embolic strokes. So even though the target vessels were open more, at the end, it didn't really improve over what the MERCI device was doing. So despite the fact that there were some issues with the design of the trial, it showed that in general was safe, and remember, these patients otherwise do very badly, and many of them die, and there's no other forms of treatment. So the FDA approved also the Penumbra device, and we have it. And in some occasions, it's actually very useful if you have kind of clots of middle size where you can aspirate them and they cannot be snared with the MRC device. Part of the issues with the bleeding were related with procedural complications because they have 2 perforations of vessels, and that is completely operator dependent. A third mechanical device that has also is in the process of receiving FDA approval for the management of a stroke. And probably, despite the fact that the results are not going to be that good, this is one of the best designed clinical trials in the management of acute stroke, is the Sentis stroke trial. And basically, this device is a couple of balloons in series that are inflated in the aorta of the patients. So you don't do anything in the brain. You just pass a catheter and you inflate it in the aorta. One balloon goes in the suprarenal portion, and the other one goes in the infrarenal portion. And the principle or the idea behind this was the observation in patients that were undergoing cardiac surgery and went into cardiac bypass, that when you increase the cerebral blood volume, but you don't modify the cerebral blood pressure, you actually trick the autoregulation and you increase the cerebral perfusion. And there was a good amount of animal experiments showing that if you increase the volume of blood that goes to the brain without changing the blood pressure, the arteries actually dilate and you get more flow. So the idea was try to use the collateral flow to improve the areas of penumbra by perfusing the brain through the collaterals. Also, the idea was that this device, because it doesn't include any intervention in the brain, could be used even beyond the 8 hours of the window for treatment with MRC or the Penumbra device, up to 14 hours to try to save more brain. And the design was done in such a way that the patients were randomized, and there was a control group that didn't receive the treatment. The effectiveness endpoint was also quite ambitious. They actually wanted patients that recover very well. Patients with an NIH stroke scale of 0 to 1, an MRI and a modified Rankin scale score of 0 to 1, and a Barthel index of 95 to 100, and a Glasgow outcome score of 5. And this was a composite endpoint. So it's quite ambitious, and these people is basically almost normal individuals, which is quite high for a stroke population. So I put already here in the graphic the results of this trial, even though, once again, they are not supposed to be necessarily compared with the other ones, but I think gives us an idea of the results of the trial. Of course, there is no recanalization because that was not addressed. There was no interventions done in the brain. But the patients with the Sentis balloon trial had a 90-day modified Rankin score of less than 2, of 32. That was exactly the same than for the control group. So these patients didn't do better than the patients that didn't receive any form of treatment. However, there was some effect in the mortality rate. There was a reduction in the mortality of these patients, and that was actually quite significant. The patients in the Sentis balloon have been the ones reported all across the clinical trials with the lower mortality, and there was no significant intracerebral hemorrhages. So these are actually the precise numbers, and as you see, there was no difference in outcomes. So basically, the trial failed to show that this was improving the patients to be functionally active. However, there was a reduction in the mortality due to stroke. They don't report the significance of this because that was not the original idea. So looking at the subgroup analysis of these patients, it seems that part of the issue was trying to treat patients beyond the 8 hours window of treatment. It seems that independently of the collaterals, by that time, probably there was not too much to save, and that significantly affected the results of the trial. In fact, patients that were 70 years old that had a time of presentation by the time that the balloon was inflated of less than 5 hours did actually well. And in the subgroup analysis, you would find that there's a benefit in the outcome for these patients. The problem is that that doesn't add too much to what we already can do with the other mechanical devices. But it kind of shows a little bit the limit of what it could have been done. And I think for researchers it's interesting because it shows how a nicely clinical trial that it was nicely done fail because of excessive ambition and really the lack of understanding that we have of all the things that occur in patients with acute stroke. And the things keep on coming. There are more things that we're trying, and there are 2 new clinical trials that are on its way. We are here both involved at UCLA doing them. One is the Solitaire, and the other one is the Trevo clinical trial, that basically they are testing these retrieval devices that look more like stents, where you actually deliver that device into the clot and pull them out. All of them basically have followed the same principle that we had when we did the Mercy device, trying to open the arteries. So to summarize, currently, a patient that presents with acute stroke should be treated with medical therapy, as Dr. Ali mentioned in the last conference, if they present within the 3 hours and don't have any of those contraindications that she discussed. If there is any of those contraindications, or the patient cannot be treated because he's outside of the window of treatment, up to 8 hours, they can be treated with mechanical devices, here at the penumbra of the Mercy device. The results are still relatively poor. The recanalization rates are not incredibly high, no more than 60%, and the good clinical outcome remains a serious problem, with only around 30 to 40% of patients doing well after we treat them for acute ischemic stroke. Now, there is another portion where we play an important role and becomes also very confusing, and part of that is due to the design of the trial, and is what to do with patients that had malignant hypertension, intracranial hypertension. And as surgeons, we get frequently consulted to treat patients with massive strokes to perform decompressive hemicraniectomies. And there's a lot of studies that have been done about it. I will review briefly for you the 5 main clinical trials. But these aspects here, you need to keep them in mind, because they are the ones who are predictors of the development of malignant cerebral edema. The first one is patients in general in poor clinical condition with stroke scales higher than 20. The presence of thrombus of the carotid terminus, the presence of nausea or vomiting when the patient arrives to the hospital. The elevation of the white blood cells is also a predictor of a malignant cerebral edema. The early involvement of more than 50% of the MCA territory, or the involvement at any point of territories usually perfused by the ACA or the PCA, and of course the involvement of the uncus. And more recently, some people have been trying to look for markers, serum markers, that could predict better who is going to develop malignant cerebral edema. Some of those markers are the protein S100B, that seems to be very sensitive and specific, and also the volume on the MRI, with a volume of more than 82 cc's being the hallmark to determine that the patient is going to develop malignant cerebral edema. And in the last 10 years, there have been 5 clinical trials that have been trying to test the effectiveness of doing decompressive hemicraniectomies for patients with a stroke. The first 3 were done in Europe, and from those we have results. The last 2 are ongoing clinical trials currently here in the United States. But there are important data that I want to show you that you need to keep in mind when you're taking the decision about operating these patients. The first thing is, if you look at the age of inclusion of the patients that were included were between 18 and 60 years old. So not very old patients were included, which is curious, because the reality is that the majority of patients that present with acute ischemic stroke that develop these kind of things are elderly patients. So keep that in mind when these results are analyzed. The second thing is that the primary outcome was not as ambitious as in other trials for a stroke. For the reperfusion studies that we do with endovascular techniques, we usually pick a modified Rankin scale score of 2 or less. In this case, it was actually less than 4. So this means is probably realistic. These are patients that can walk but need assistance, and other than that, they have deficits. So keep that in mind also. This is what is considered a good outcome. And the results are a little bit all over the place. They show that there is some benefit, but that is not necessarily that clear. The mortalities were clearly reduced, but the good outcomes, even though were very high in these first 2 trials, the largest of the trials, that was the Hamlet, showed that there was actually no difference in the different groups that were treated with the decompressive hemicraniectomy. Which brings then a serious question that has not been addressed by any of these clinical trials, is when you go and do the compressive hemicraniectomies for these patients, clearly you're saving lives. Probably you need to do 2 to save 1. That's quite good. However, you are not necessarily improving the outcome. And I'll show you in more detail that when you put these things together in a nice meta-analysis that somebody did. Which means that we're saving lives of individuals that are having serious neurological deficits. And that is problematic and needs to be addressed more carefully. So when they published the Hamlet study, they also did a meta-analysis of all the other 3 studies. And basically what it shows is that there was a mortality risk reduction of almost 50%. That's very good. So you need to treat 2 patients to prevent 1 death. That is effective. However, the functional outcome at 1 year was not that good. If you look the shifting of the modified Rankin scale scores between the best medical treatment group and the surgery group, what you see is actually that modified Rankin scale scores of 3 or lower were basically the same for the best medical group and for the surgical group. When you use that modified ranking of 4, that is patients with some disability, then you get some difference, and it seems that the surgery is more effective. And that represents the majority of the shifting and the expansion of the treatment group. So when families, because usually these patients cannot be consented, they are suffering of malignant intracranial hypertension, when families are consented, we need to be very clear that we are going to have a good chance of saving the life of these patients, but the cost of that is also that there is an increase in the risk of having disabilities. And that needs to be clearly understood by our colleagues in neurology, the intensive care teams, and the families. If we do it like that, probably it is in general a good idea to try to do these procedures, and it seems that may be effective. Now, something else that is interesting in the meta-analysis is related with those age groups that I mentioned before. For patients which age was lower than 60, that's basically everybody who was included in these studies, and that were treated acutely within 48 hours, it seems that the results show a reduction in the absolute risk of having disabilities or death that was significant. So this lower portion is, represents the absolute risk reduction of dying in the 3 studies and combined, and clearly you can see that there is a significant risk reduction of around 50%. If you count the modified ranking scale of 4 or more, meaning patients who have severe disabilities, there is also a significant risk that the patient will be disabled. And with the modified ranking scale of 3, the thing is just barely significant. But this brings, again, the same point. It's just, we can do it, we're going to save lives, but the cost is that the patients will be most likely disabled. Good thing for the CREST trial, because in the past, every time that I talk about carotid angioplasty and stents, it was always a discussion with the surgeons and endovascular people, and there was a lot of tension of what to do. But to be clear, the extracranial carotid disease is a very important part of what we do. And it's also very important in stroke because around 25% of ischemic strokes are due to carotid disease. The carotid endarterectomy is still the gold standard for carotid revascularization, and if anything, I think undoubtedly the clinical trials that have been done, and especially the CREST, that was probably one of the best designed trials to address this issue, show that carotid endarterectomy is still a fantastic treatment, and it should be the form in which the patients are treated when possible. The carotid endarterectomy is supported by very solid studies that have been published for many years, and you are familiar with all of them: NACE, the European study, the ACAS, and the asymptomatic carotid surgery trial. And this table summarizes the results of those studies, and basically what it shows is that the 2-year ipsilateral rate of a stroke and death went from 26% in medical therapy to 9% in the carotid endarterectomy in the NACE trial. This means there is a risk reduction of around 45% of having a stroke. These 2 studies were for patients that were symptomatic. For asymptomatic patients with stenosis that had more than 60%, the ACAS and also the asymptomatic trial show a reduction of around 50%, from 11% in the medical branch to 5.1% in the carotid endarterectomy group. However, the interpretation of this is a little bit difficult to just necessarily apply to the clinical practice, and let me explain why. If you have a patient that is symptomatic and has a carotid stenosis of more than 70%, it seems very clear, and it is the case, that probably you should offer treatment for that patient. And the carotid endarterectomy can reduce significantly the risk of a stroke or death. That is very clear. Now, you need to maintain a rate of complications that is below 6% is usually what is applicable, which means also that you need to do a good volume of those things. And it has been clearly shown that the more you do, the better you become doing these carotid endarterectomies. For the group that is asymptomatic, you need to go a little bit into the design of the clinical trial to really understand if the meaning of this is that you need to offer carotid endarterectomies for patients that are asymptomatic that are found to have an stenosis of 60%, because that sounds a little bit aggressive, and it is. When you look at the trial, the authors actually describe how they pick the patients that were treated and included in this trial. They actually reviewed 25 patients for each one that was included in the trial and randomized, which means that this effect is only applicable for patients in a very selected population. And in fact, some other people have been looking at what is the real effect of doing carotid endarterectomy for patients that are asymptomatic. And you will need to treat probably 25 to 50 patients to benefit one. And this risk reduction is a numeric trick because it's a reduction of 50%, but what it means is that when you treat 100 patients, you have the chance of 2 having strokes if you don't treat them, and 1 having strokes if you treat them. That's a 50% reduction. So it's not that in the general population you're reducing 50% the risk. That means that the indication really for asymptomatic patients is a little bit more difficult to define, and it cannot be done exclusively with the results of these 2 trials. In fact, the majority of experts doing carotid endarterectomies would say that they will wait until the patient has an stenosis of around 80%. So stenosis that are more than 80% could be a good reason to treat. Or in other conditions, a patient that has an occlusion of the carotid in the other side, or a patient that has in tandem lesions may be considerations to treat these patients. But keep that in mind. Now, once the endovascular people start doing angioplasty and stent, there was a lot of interest in trying to prove that that technique was better than surgery because it was less invasive. And probably you have heard a lot, because this is frequently discussed in congresses, of all the multiple clinical trials that have very variable results in terms of effectiveness of carotid angioplasty or stent. To mention some of them, the Cavatas study that was the first one that was done, 90% of these patients were symptomatic, 10% were asymptomatic. This was randomized, and 253 went to surgery, 251 to endovascular treatment. The carotid endarterectomy risk of a stroke of death at 30 days was 9.9. In the angioplasty group was 10%. And at 8 years was 8.6% for the surgical group and 11.3% for the angioplasty. But there was a significant amount of re-stenosis with the angioplasty and stenting. Now, these results basically show equivalence. It seems that the result is about the same. But the problem is this re-stenosis. Now, if you look at the trial, this was really one of the first trials that was done, and not everybody was stented. These patients were angioplasty only, and angioplasty re-stenosed very rapidly, so that kind of doesn't count too much. And many of these patients didn't have the distal embolic protection devices. So it's difficult to apply with what we do today because we will not angioplasty patient without stenting. The SAPPHIRE clinical trial was not a randomized study that included both symptomatic and asymptomatic patients that were considered high risk for surgery. And basically what they showed was that patients with carotid angioplasty and stent had a lower rate of strokes and death. But they also added MIs, and as you will see, that is kind of important because patients that have surgery have the tendency to have more MIs than patients that have endovascular procedures. At the end, this was a positive result for the angioplasty and stent. And then there were studies that showed the opposite. There was negative results for angioplasty and stent, like the EVA-3S and the SPACE. Well, this was almost equivalent, but the EVA-3S that show a higher rate of stroke and death for the angioplasty group, almost 3 times higher than for the patients with the surgical group. So kind of in order to address all this issue, one of the best and nicest clinical trials that has been done for anything that we do in endovascular treatments and surgery was the CREST trial. which purpose was to compare the carotid angioplasty and stents versus endarterectomy for the treatment of stenosis to prevent recurrent strokes in symptomatic patients that had TIA or mild strokes or asymptomatic patients, and this was prospective, randomized, controlled trial with a blinded endpoint adjudication. And it has also a composite endpoint that was stroke, myocardial infarction, and death during a 30-day periprocedural period and then in the follow-up at 4 years. And these are the results of that study. You see how the population was distributed between the angioplasty group and the endarterectomy group. And basically for the composite primary endpoint of stroke, MI, or death, there was no difference between the two groups, which showed that none of them is superior, but they're kind of equivalent. Now, if you look a little bit more at the details, what you notice is that the rate of deaths is very similar, but the rate of a stroke is actually higher in the angioplasty and stenting group, 4.1 versus 2.3 for the carotid endarterectomy. And this is in the periprocedural period. This is significant. While the rate of MIs is higher for the surgical group compared with the angioplasty and stent. Now, some discussion that the vascular surgeons have presented, and is very valid, is what do you prefer to have, a stroke or an MI? Well, the strokes clearly have an impact on the functionality of these patients, and probably that needs to be honestly discussed with the patients. Because at the 4 years, if you put what is significant for a patient that is having a stroke or death, there was also a significant difference, and it was higher the risk of having strokes and death for the angioplasty and stenting group. Now, the design of the study was not to look at those two things. It was to look at the composite endpoint, including the MI. And MIs can be quite disabled and compromise the life of patients. However, it is clear that angioplasty and stenting, and this was done by people that was very well trained and with a distal protection device, may increase the risk of having strokes. And therefore, I believe that probably is a good idea to think about the patients that are going to be offered this strategy, and probably only do it for those that can be considered high risk for surgery. Kind of to say what I said at the beginning, carotid endarterectomy is still the gold standard of treatment. But if the patient have conditions that make that surgery difficult, or the risk of MI significant to compromise his life, then is when angioplasty and stenting may have a role. So this one is the freedom from primary endpoint. You see is about the same. And there is an additional factor. It was that traditionally was thought that patients that were old were high-risk surgical candidates, and many of those patients were then sent to be treated with angioplasty and stenting. If you look at the results of the CREST trial, what happened is actually the opposite. And the hazard ratio for a primary endpoint becomes better for angioplasty and stenting for all the patients that are younger than 70, while patients that are older do better with surgery. And the reason is that these patients have more tortuosity of the arch, more atherosclerosis in the origin of the vessels, so they have actually a higher risk of suffering a stroke. So, being old is actually not an indication for angioplasty and stenting. If anything, it should push the treatment towards the surgical side. And younger patients can do better with angioplasty and stenting. All right, let's go to the final part in the last 15 minutes or so that we have. Now, there is another condition that is very important and where we as surgeons can play a role. I wish more people have been here, because this is actually very novel, I believe, in the treatment of a stroke. There was a large study that was comparing the effectiveness of aspirin versus warfarin in patients that had symptomatic intracranial stenosis, that is the WASID study. And some of the data that I'm going to show is taken from there, but in general it's well known that 10% of all the strokes that occur happen to patients that have not stenosis of the arteries of the neck, but intracranial symptomatic stenosis. That accounts for around 90,000 cases every year. Now, symptomatic intracranial stenosis carries a very high risk of recurrency, approximately in the WASID study around 15% in the best medically treated patients. That means that if somebody has stenosis of the arteries of the brain with the best medical therapy, the risk of having a stroke every year is around 15%, which is quite high. In subgroup analysis of that WASID database, there are conditions that make the things even worse. African Americans and females have higher risk of having recurrent strokes, and that can be as high as 25% of patients. So There was an interesting clinical trial that probably you heard. I think we received all an email with the news of the failure of this trial, that it was the SAMPRIS trial. The study was the first prospective randomized clinical trial to compare aggressive medical therapy versus aggressive medical therapy plus angioplasty and stenting of the intracranial arteries. And patients that have severe stenosis were included. Basically, the medical therapy is the standard aggressive medical therapy that we do today with aspirin at a high dose, clopidogrel at 75 milligrams, and intensive management of vascular risk factors like blood pressure and diabetes. On April of 2011, the study was stopped, and the reason why it was stopped was because of the high rate of complications of patients with stenting and angioplasty of the intracranial vessels. So they have recruited 60% of the patients, and 14% of the patients treated with angioplasty and stenting experienced a stroke or died within the first 30 days after enrollment, compared with only 6% of those that were treated with medicine alone. In addition, there were other 5 stroke-related deaths 30 days after the enrollment, and all of them occurred in the stenting arm. There was only 1 stroke-related death in the medical arm within the 30 days of the enrollment. That is, in general, bad news, because basically angioplasty and stenting show not to be necessarily safe for the treatment of patients with intracranial atherosclerosis, and we still need to see what is the final report of the data, but it's not encouraging that the study was stopped because of the high rate of complications. Now, in a related issue, but not the same, a surgical trial that was very praised by all of us, there was the COST trial, also failed and was stopped. The COST trial was a prospective randomized clinical trial to determine if extracranial intracranial bypasses combined with best medical therapy could reduce the risk of a stroke in patients with carotid occlusion. And this is kind of the sequel of the famous EC-IC bypass of the 80s. During the 80s, there was this very nice idea that if you revascularize the brain, you may reduce the stroke in patients that have stenosis or occlusion of the carotid arteries. One of the problems of that study was that it shows no difference, and there was really no benefit from doing the surgery. Then the bypass surgery failed in disgrace, and not too many people continue doing it. Many people look at the trial and try to figure out why the trial failed, and there was 2 basic ideas. There was clearly one subgroup of patients that was not doing very well when you did bypass, that were the patients that have stenosis and not occlusion. Part of the idea was that maybe patients with stenosis, when you put a bypass, you will have areas, usually around the M1, of a stagnant flow, where you have flow that can go in both directions, competing from the carotid and the bypass, that would end up thrombosing and producing more strokes. The second one was the idea that maybe the patients were not very well selected, and that these patients would be better selected if we do better studies. And Dernane and some other neurosurgeons have dedicated their life to do fantastic studies in how to determine who is going to suffer a stroke and understand better the concepts of the perfusion of the brain. And the concept of the misery perfusion was developed, this territory of brain that is subject to ischemia or to a hypoperfusion, to a point when the oxygen extraction fraction is increased because the brain, the concept, the idea is the brain is about to suffer a stroke. With the idea that the oxygen extraction fraction was a better marker of which patients would suffer of strokes, the COST trial was designed, including patients that had occlusion of the carotid artery and that had actually abnormal oxygen extraction fractions. However, the COST trial was also stopped. And to clarify and keep this in mind, it was not stopped because of surgical complications. The issue was not that the surgeons were not good or there was problems with the bypass. The issue is actually more complex. It was stopped in June because the futility analysis of 139 patients showed that there would not be benefit from doing the bypass in patients that were having good medical therapy. The intent to treat analysis was based in those patients that were randomized, 98 to a medical therapy, 97 to a medical therapy with bypass. And there is very interesting data that comes from this. The first thing is that the graft patency was excellent, and in the last follow-up was 96%, which means all these bypass were working. So the issue is not that the bypass didn't work. Bypass was working. Now, all the studies of the pathophysiology of cerebral hypoperfusion were kind of correct to some extent because they putting a bypass improved the oxygen extraction fraction. So the physiologic measure was achieved, and that endpoint was going in the good direction. These patients had a reduction in the oxygen extraction fraction. So the bypass was accomplishing part of that function. However, the rate of ipsilateral ischemic strokes was 14 in the surgical patients at the 30-day follow-up. And this rate of 15 was not different than what has been observed in the EC-IC trial. So actually that speaks of how well done was that EC-IC trial. First, the bypasses in that trial also worked consistently. But second, the rate of stroke was the same. Now, there were 6 additional surgical patients that experienced ipsilateral stroke after 30 days, and the 2-year primary endpoint of stroke and death in the surgical group was 21%, and in the non-surgical group was 23%. So basically what they show is that there was no difference, and it was thought that the medical therapy was doing so well that there was no way that the bypass was going to improve that. And I think that brings 2 points. One is, yes, medical therapy is doing well. However, 23% rate of a stroke is still quite high. It's the same that WASIT and other studies have shown. So patients with intracranial symptomatic stenosis have a risk of suffering another stroke of around 23%. The second thing is maybe the oxygen extraction fraction doesn't necessarily mean that somebody is going to get a stroke, because all these patients improve, however, they got strokes. And maybe that selection criteria was not necessarily the best idea. At the end of the day, the COST trial is stopped, and we have to see what is the final report that the authors do and how they present the data to see if there's anything else that can be learned from this. But it's a problem, is that what are we going to do with these patients? We still see a significant amount of patients that have intracranial symptomatic stenosis and that are having symptoms despite best medical therapy. And this is something that we are trying to address, and we will see how it goes. And it's basically based in observations that we have done in patients with similar conditions, that are the patients with moya-moya disease. Patients with moya-moya don't have necessarily always occlusion. So if they have occlusion, they have some forms of forward flow through the moya-moya collaterals. And in the past, it was thought that the EDAS procedures were exclusively good for pediatric patients, and that the adult patients would not benefit from that. However, it has been our experience here that we actually see clinical improvement of those patients. So a few months ago, we published in Neurosurgery our experience in 42 patients with 63 hemispheres that were revascularized. And actually, the clinical results were very encouraging. The patients did quite well. 95% of them stopped having strokes at the follow-up and stopped having TIAs, and actually none of them got strokes. So I decided to look at the patients, and once samples failed, the neurologists have referred more patients to be treated because they are still symptomatic despite best medical therapy, to be treated with a different form of revascularization, that is this EDAS. And what I'm going to present at the end today is this report of 13 patients who underwent unilateral EDAS for conditions different than moya-moya. Some of them atherosclerosis, some of them unknown etiology stenosis. 12 of the 13 patients had simultaneous Burholz with duropial synangiosis, frontal or frontal and parietal. The average age was 38 years old, which also is an issue. Remember, these are a little bit younger patients than usually patients that present with atherosclerosis, but it's what it is. 9 women and 4 men, and the follow-up, the mean follow-up was 54 months. All the patients had angiography before the procedure and at 6 months after the procedure. And basically, we were considering for these study patients that presented with symptoms of cerebral ischemia, transient ischemic attacks, or non-debilitating strokes within 30 days from the time of the treatment, with angiographic evidence of intracranial stenosis that was not suitable for angioplasty or stenting. Many of these patients were recruited before we knew the results of samples, or individuals that had failed stenting and had MRI perfusion studies showing deficits. This is a little bit of the detail of what we do, but we did these calculations of the size of the cella to correct for magnification and do the quantitative analysis of the angiograms before and after the surgery and estimate the size of the vessels. And the results are very encouraging. The first thing is that in the population that we have, all patients were symptomatic, and all of them had intracranial stenosis of 70% or more documented by angiography. 5 of them had TIAs, and 8 had strokes that were not disabling strokes. One patient had been treated before with stenting and had failed twice treatment with that technique. Now, in the clinical results, in the mean follow-up, that is 4 years, there was patients, 85% of the patients didn't have symptoms at all. They were not having TIAs or strokes when we saw them for the last time. There were patients that have TIAs at that time of 4 years, 2 of those patients. One had additional boreholes done, and that patient actually in the last follow-up stopped having symptoms. The other patient had more boreholes done. That patient continued having symptoms, so that patient had a bypass, and that patient continues having symptoms after the bypass. So there is one complete failure that failed for everything. But this is slightly higher if we account for that patient that required an additional surgery. But the other 11 patients didn't require any additional surgery. None of the patients have strokes or none of them die, which is actually remarkably good because this is a follow-up of 4 years. So that one is already looking quite good. Now, something that is very interesting is that 10 of the 13 patients stop having strokes almost immediately after the surgery. The majority of them actually improved within weeks. And by the 3rd month, none of the patients had strokes or TIAs. Only those 2 patients that had recurrent strokes after years that I mentioned above were having symptoms. The others didn't have any more symptoms. And all patients' functional status was at least as good as it was when they came. Some of them have already deficits that were not disabling based on the inclusion criteria. Now, when we look at the angiograms, this graphic shows the change between the pre and post size of the superficial temporal artery proximally, the superficial temporal artery in the midpoint, and the middle meningeal artery. And there's kind of a very interesting finding. In all the patients except one, there was an increase in the size of all these 3 point measurements. The STA proximally increased in size of around 52%, in the midpoint 74%, and what was a little bit unexpected what occurred was that the middle meningeal artery also expanded, and the growth was actually more than for any of the other vessels, was 84%. This is interesting because you would expect that by dissecting the STA, you may actually release the tissues around, and just by doing that, the artery may look bigger. But with the middle meningeal, you don't dissect that, it's trapped in the dura. However, it shows an increase in the size, which hopefully would correlate with an increase in the flow, or at least that's what we can suspect based on the clinical improvement of these patients. And in 8 out of the 13 patients, there was actually direct connections between the extracranial arteries and the intracranial arteries that form spontaneously. We didn't do any anastomosis in the OR. However, these patients developed this anastomosis. You can see this quite robust here in the left lower corner, where you see actually an MCA branch filling through these naturally formed bypasses coming from the extracranial arteries. It's almost like the tendrils of a vine, the way these vessels from the extracranial circulation connect to the intracranial vessels. Now, of the 8 patients that have frontal boreholes, 4 demonstrated neovascularity with just blushing of the brain tissue. 1 had a direct anastomosis, that is this patient, where you could actually see a branch of the MCA filling by a branch of the middle meningeal artery that was going to the frontal borehole. And of the 6 patients that had parietal boreholes, only 1 had neovascularity and none had direct connections. The complications of the surgery in general were relatively low. There was no major complications. There was a wound dehiscency, 1 patient that developed seizures that were treated with medications, and 1 patient that had transient hyponatremia, but there was nothing else, and there was only 1 reoperation, that was this patient with the wound dehiscency. So, of course, this is a retrospective database. Clearly, the patients are being selected. That is shown because the age is not exactly the same that you would expect for the majority of patients that are going to present with intracranial symptomatic stenosis. However, it's very encouraging that there may be some other alternative, and we're working with the neurology stroke team to try to develop a clinical trial where we test this in patients with symptomatic intracranial arterial stenosis. We have issues because it's not easy to define a marker different than the clinical presentation of the patient, because we know that the oxygen extraction fraction is not necessarily the best, and perfusion studies may not necessarily be the best tool to identify the patients. However, it seems that indirect revascularization may be safe and may be clinically effective in a group of patients. Defining which group of patients may benefit from that is what we have to do. There was also a objective enlargement of the arteries, and that seems to correlate with the clinical improvement of the patients and may indicate improvement in the cerebral blood flow. And of course, there's more things that need to be done, but I think the general message of the conference is actually more books should include chapters of stroke management for neurosurgeons, because we are doing more and more, and we will continue doing it. And despite the results that are limited in some aspects and have issues in some others, there is a good amount of people doing very good clinical research trying to address the issue of stroke, and that involves us directly as neurosurgeons and what we can offer for these patients that suffer such devastating problems. All right, very good. Thank you very much.